Thank you, Mary. And partially thank you for the introductions. I was wondering whether it was me or it was a different person, and I'm happy. And also I was asking her how many hours has she allowed me to speak. But I know you have been in here for quite some time, and I want really to make it very short. So I want to recognize the president of the College of Anesthesiologists of East and Central Africa, Kaneska. Is he here or she around? Oh, he left this morning. But also I want to recognize the president of our association in Uganda. And all of you in your different capacities. I have definitely had the opportunity to listen to 1.5 presentations, but also I sat near Ivan. He briefed me about his presentation, and he told me he had to answer my questions. And then I told him that these are all our questions. So I'm happy definitely to join this fraternity of Anaesthesia, because they used to feed me a lot with the anesthetic agents when I was operating. So I hope now it has changed, that the anesthesia agent don't only act on the patient, but also act on the what? On the surgeon who is operating. So you all know that it's definitely an honor to join you, and I am sure that probably your facilities are missing, because I think you've depleted all the anesthesia cadres in their different facilities. So I hope all other who have got excuse of referral. I have definitely had my own experience working with anesthesiologists and anesthetic officers. I will not speak in all of them, but probably I will speak to one of them. And I will still want to speak to the one when I was a postgraduate. And that time, if there's anybody whom you would want to be your friend, it's really an anesthetic officer or an anesthesiologist. Because you have this long list of patients to do what? So sometimes even when they came with their patients, whom they call their relative, you have to do what? To work on him, because if you don't do, then you might not be able to have a chance to do your what? To do your list. But that's not what I wanted to speak to. I wanted to speak to issues, particularly when during your surgery of your first case and you have a fatality, then you are told that this is already bad luck, I'm not willing to continue. And you have got a long list, and as a postgraduate, if you are not able to finish this list, it means tomorrow you have to miss class because you have to remain to do what? To finish this list. But I think we learned our ways of how to maneuver over it, and we work together and be able to do what? So health systems and service delivery definitely means that you have to have teams, because whereas I would be there with all my good skills, but I can't be able to proceed without what? Support from an anesthesiologist or anesthetic officer. So I want to thank you for the lives which you save. So when we talk of that maternal mortality rates have come down, I think there is nowhere they have indicated this was contributed by the anesthesiologists. Nobody. Yesterday I was in Mbarara, and definitely in the surgical discipline, I think they have orthopedic, ENT, maxillofacial, urology, cardiothoracic, all those disciplines. But I'm sure that all of them are competing for what? One other cadre of what? Anesthesia provider. So, and each of them cannot do what? They cannot be able to achieve their outputs because they do not have what? The requisite number of anesthesiology, because each one would have required what? Its own. So that means that the specialization is moving faster But we are not looking at a cadre who could be able to facilitate what? All of them working. So you can see that becomes a very big challenge. So I am happy definitely to join you in your 10th conference. I'm happy that you've been consistent. But I thought I joined even the previous one, but probably this is the one I recall that Mary was in my office. She did indicate, and she's lucky that my secretary reminded me that I had this commitment to come and speak here. Because at 5, I have a board meeting to do what? I hope I would have finished by that time, though I had requested for her to give me 1 hour to speak. So I also want to commend you for choosing a relevant and a forward-looking theme of access to anesthesia, critical care for all Ugandan challenges and opportunities. Because for every side, there definitely what? Some challenges. But also she did highlight some of the issues here. I think about 1 month ago, I think in this same hotel, the Health Service Commission convened a recruitment planning meeting of regional referral hospitals and national hospitals. Unfortunately, I was not able to participate. But I am just wondering that because the system, the way now it runs, that each of these individual hospitals have got their own what? Budgets, and they manage them. So the issue is that if like now the one has gone to Masaka, it will be in your interest to get to the office of the director, so that if there's any consideration, then it should be what? Because I am sure that where there are 2 people, their chances of staying are much better than where there's one what? 1 person. So we need to be able to see that. But the issues which I want really to do what? To contend and be able to, that they are always where we need to begin from. And that's why you see that probably at one point, 1 person has to be what? To be there. And I'm sure that if there's already somebody there, there's a highest possibility that the second person will do what? Will go to that place. So I want to speak that when this position get advertised, let's do what? Apply them. I know it's very notorious that sometimes if they put positions and they are in Moroto, it attracts no one. But sometimes what I advise that you first get there. You first get what? Then the issues of deployment, we can do what? We can speak to it. It's not really cast on what? A stone that is hard that to do what? We look at all the interests of what? Of service where we can be able to do what? Be able to deliver the service. So I want to encourage you to do what? So as a surgeon, definitely I did work in a rural settings. I worked in Gulu during the time of war. And that time I was a medical officer, but the earnings I was getting was really a lot of money that time. Because first of all, I was a seconded staff, so my government salary was one, but the facility was also one. But also the reason why I was having the money is that I could not spend the money. Because there was no time to go to town to do what? To spend the money. Because every time you sort of going to town, they have brought a truckload of what? Or people who have been injured, whether the civilians or the soldiers who are what? And so we kind of developed a saying that work in a missionary hospital will never get finished. Because you will work and do what? But I must say that it gave me a very good experience, particularly for young people. Very good experience. A very good experience. And then you can ask, then why did you come back to school? I came to school because I did not want to continue working as a mechanic. You know, a mechanic, he can fix everything. But if you ask, why did you do that? He will not tell you why you want. So, my reason I came is that because how do I get argument? And how do I get when, as they say, that the best surgeon is the one who knows when not to do what? To operate. Because otherwise I would operate everybody and have poor what? Poor outcomes. But if you talk to from orthopedics, from endoscopy, from talk about any operation, I could do what? I could do it. I recall very well that in my first week in Mulago, I was assigned with some other colleague who was in second year. There was a person who had a sickle mass. So we were there with the interns and the HHO, and he was saying, the intern was suggesting, let's biopsy, and you know how, can you biopsy from a cecum? Then I told the gentleman that, why don't we do a resection? Then he said, no, let's change. Now I change now, a first year, change the other side to become what? The surgeon. I know definitely that the colleague probably might have owned in the world that he did this operation, but as a first year, what? So that's the experience which definitely comes with working in the rural setting. But the success of any procedure does not just depend on the strength of one, of me. It depends on many people. Because there have been others where you have done very good surgery. Then when they are just extubating the patient, you are notified that the patient has what? Changed the condition and passed what? Passed on. So you would have wasted your energy, wasted a lot of resources, but wasted a lot of... I think Mary has spoken to you that when we go to the ministry, there were only, I think, 2 where you found that many people were looking at communicable, non-communicable, NCDs, and then the other aspect of, which is like health promotion. When you look at our reports, annual reports, it's reporting about how many outpatients, how many admissions, but it's not talking about how many surgeries you have what? How many? If it talks about the surgeries you have done, or probably anesthesia you have given, if it talks about it, it talks it about in terms of minor and major what? Surgeries. And you can have this soft tissue injury, which can take you 3 or 4 hours to work on, but it's categorized as what? A minor what? A minor operation. So it means that there are not many people who appreciate what we do because we don't count the numbers of what we want, of what we do. So one of the things, in addition to now that we have this as part of the essential healthcare package, which I've been working with Professor Moses, is putting that, how do we put indicators so that you can be able to tell exactly what is Mulago doing, what is Barara doing in aspects of what? Of surgery. What are the different specialties? Then you can be able to do it. So I would really want that we capture this information. So definitely we see a weakness in the workforce in terms of numbers, the infrastructure, the equipment. Mary again mentioned that we did this investment for critical care equipment. I engaged my colleagues, for special at that time, I wanted to get some funding from the Global Fund. But he couldn't succeed in it because that time I saw that if I was able to get 1 or 2 people in each of those places, then we should have been able to do what? To move them and be able to utilize that equipment. But the question now we ask, because as I said that they are too critical. I saw the one in Barara yesterday. I was told it will get finished, I think get finished this month, the neonatal intensive care unit will get finished this. Then in Aroa, They also have, and I think Hoima. So if you look at where do we get people to do what? So now that's why we need to be able to look at it. How do we invest? How do we invest in infrastructure? You have not invested in what? Human resources. So we need to be able to see. Aga Khan is coming on. It needs human resource. Luboa is on. I want to confirm you is on. Because some of you might be doubting. It's still what? It's coming. Until you need what? Human resource. The regional referral hospitals have increased their capacity. I mean the general hospitals have expanded what? Their capacities. But the issue is still that we need to get people what? Recruited. So we need to be able to look at that the opportunities do exist. At least now, it's just that probably just a matter of time that the people get recruited. But at least the spaces are what? The spaces are there. So the other aspect definitely is how do we strengthen partnerships? I think definitely we have been working on that. And that's why we saw that we needed to complete our National Surgery Obstetric and Anaesthesia what? Plan. Because if you have it, it becomes a tool for you what? To advocate. Because it cuts on all these system building blocks. Infrastructure, anesthesia, and all those other equipment, human resource. So we need to be able to do that. So the association definitely should be able to liaise with the ministry. The ministry is not just a space, it's for all of us. We should be able to come and we do what? Engage. Our doors are open, we can be able to do that. So your leadership in developing standards, advocating for safety and training for the next generation in shaping is definitely key. And I don't want us to talk as if we are on the other side. But you know that we can also be on this side. We can be providers, but also we can become patients on the one. So we need to be able to look at that. We would want to have a quality care system for both our patients, but also for our own what? Our own selves. So we need to be able to look at that. So the ministry counts on professional associations like yours as a mirror of reflecting on realities, keep challenging us. Things might not be what? Working well. But those who are older than me, you know definitely they were not any better. I was telling someone that at one time, I had to close an abdomen with the 3-0. How do you close an abdomen of vandals? Probably if it's a neonate. An abdomen of a person of at what? 3-0. Silk 3-0. The good thing that those days, we still had those reusable what? Needles, the big ones where you could put it. So you could be able to double. So that's the reason why we're managing to double it. Otherwise, you'll have a burst abdomen, and you know what the outcome would be. But our patients used to do very well. Despite all what? You'll find that our SH, a Steinman's pin here, sutures here, gloves. But things are progressive what? And that's why today I was speaking to the heads of the institutions. I was telling them that if they do not involve people like you, hospitals are not run because of drugs. They are run because of medical what? Supplies. So if you're not able to provide them, if you go on putting your priority in buying amoxicillin and you have not bought probably sutures and bought gloves, you have not bought endotracheal tubes, then you won't be able to do it. Because, as I can tell you, that you can move to town, and even if you have 500 shillings, you can buy Panadol. But probably 500 cannot buy you what? Cannot buy you surgery. So it means that you should be able to, the hospital should be able to provide that what? That service. So you need to be able to see that, do you provide Panadol, provide amoxicillin, and when the person comes, he doesn't have a blood giving what? Set. Then you get the third delay. Then we look at that this patient came, threatened rupture, but now he has ruptured and you have lost the baby and you are losing the one? The mother. So we need to be able to, so that's the reason why we're saying that when we talk of this medicine and therapeutic committee, do anesthesiologists or anesthetic officers, do they represent themselves there? Because that's where the procurement plan is what? Is made. Because if you don't, then when they bring the things, then you find that those for provision of anesthesia are not what? Not there. So we need to be on the table. So we need to be able to be part. We need to provide leadership. And in you know what? You all know that at the heart of all of it, let's not forget the patient, because the newborn baby who needs neonatal intensive care, the child who needs emergency surgery and appendicitis, the mother who develops complications, and the accident victim, all of them will need critical care. So if you improve surgery, you would have improved what? All the other services, because the things to improve surgery, improve all the other system blocks. So for you to address NCDs, for you to be able to address all the other maternal and child health services, survival, you need to be able to address what? Address surgery. I'm about to conclude, because some of you are getting worried. So what do we do? Because we can speak here the whole of this evening, but what do we need to do? I want you to do that. Take advantage that now you have a clinical DG who understands, and I know it very well, that you need anesthesia. Patient survival will depend on how what? It's not how good you have done the surgery. Professor, let me tell you this other story. I did operate a child. That's why sometimes they say that don't say this is a minor or major operations. And it was circumcision. And it was a child for my very good friends. And they used to own a bus service in Aroa, of which I was privileged. If I wanted to come to Kampala, I would board freely. Because that's kind of how I build what? The friendship. Then we take this child, and after circumcision, definitely they take to recovery room, take back to the ward, and the child gets cyanosis in the ward. I had to leave the table. I think I was doing a goit at that time. I had to leave the table and run to the one to resuscitate. Successfully, we're able to resuscitate the one. This is just a circumcision, but you can see how it can get complicated, because it looked like the child got overdose of what? Anaesthesia. And probably we also had to take the child back to the what? To the ward, before it was fully what? Recovered. And you know, most of our hospitals are in town. The relatives had already run past and crossed out of the what? Of the hospital to town. So you can see that a patient can come walking, and sometimes the patient cannot do what? Does not leave the table what? Walking. So you really need to be able to look at interest from the time the patient is operated to the time when it's on. And I think that's why the late Professor Kiriabwire, after surgery, he will not start another operation until he's sure that the other patient has what? Fully recovered. Because he really wanted to make sure that the patient is what? Recovered. So we need to be able to have those standards. That's why we need to have those what? Standards, so that we can be able to look at what we build. so that we build a sustainable and strong anesthesia workforce. We ensure that there's quality through standards and accountability, so that we place anesthesia and critical care at the center of the health system, so that you can look at all these things that we cannot be able to do. We cannot be able to achieve them if we don't do one. We cannot be able to do. So I really want to advocate that the different spheres that we are able to do one, they might be difficult now. I know all of you know there is that book in the Bible, but I think even the ones who were making it made sure that they put it at the last chapters in the one, in the Bible and the book of Lamentations, so that we don't need to go into that one, that the system, it will be you and me to do what? To improve it. So you shouldn't leave that it's Ministry of Health or government, because when you need it or your relative needs it, we need to be able to do what? To see it. We need to be able to see how do we put practical what? Solutions. How are we able to address what we require? And sometimes what we require is that, have you just checked the systems? Have you been able to do one? Have you been able to look at it? And that's why we should be able to have biomedical engineers there and all the other aspects which we can be able to support. So I'm looking towards your support, Mary, Adam. I hope this thing happens. I don't know that this Christmas also will pass and we still do not have the anesthetic national the NSOPs in what? We really need to be able to do that. We need to look at the indicators. How do we look at the indicators? Surgical one? Indicators. We need to be able to look at them so that we can be able to gradually count and for you to plan and invest in what? But also telling you the morbidity of the cases which are what? We need to be able to do that. We need to strengthen the air system, emergency response to surgery. We need to be able to close it. I was in Mbara again and I looked at this very good call and dispatch center. And I saw that we should have sort of putting it, yes, to coordinate the ambulances, but we should also have been able to see that we need to put in a very good accident and emergency what? Unit. Because now if the ambulance access brings you from there, they should be able to get what? Where they should be able to take care of what? Of you. So we need to be able to have this system thinking approach so that we don't look at things in what? Vertically. So I think it might have happened, but now we need to see how do we close what? How do we close these gaps? So as I conclude, I should have started with this one. I wanted to congratulate you for the 10 years and thank that you for your contribution to the healthcare system. Let the 10-year conference not only be to come to celebrate, but also mark the beginning of a new decade of leadership. So of anesthesia and critical what? Critical care. I know when Erasmus was here, it's written as that all of us are going to die. And when he said like that, there was no question for what? Question for him. Nobody would want to do one question. But while we are here, it means that we have to make what? The contribution which is necessary. We need to make the difference, which is what? Which is key. We need to recognize, prioritize, and support essential services for every Ugandan. It might be in your relative. Since I mentioned every Ugandan, now I tell you another story. Last story. I had an anesthetic officer whom I thought he was really a king. Because getting him to work was very difficult. Very difficult. So I think one time they went to call him. I think this was some time before I joined Aroa. So they went to call him, he refused to come. And finally he came. And I found Akela, his actual real brother, was the one who was dead. It's a true story. So I hope when you're in the room, when they call you, you don't refuse to do what? You don't refuse to come. Because you will find that probably the person who is on the table is your what? Your relative. Or somebody whom you do what? You know, or a relative of somebody. So I want really that you look at that. So I want once again to thank you that the ministry is ready to work with you to make this a reality. So that we just don't come to these conferences, we speak and do what? We want that we make it what? A reality. I'm going to take it personally on my side to see that we recruit what? Another sociologist. But when they advertise, I kindly request again that you apply. Because otherwise, my thought, I will not be able to actualize it. Let's be able to do what? Let's accept and be able to do that. So I want to thank you and wish you a successful meeting, an inspiring conference. It has been. And see how surgeons normally don't obey instructions very well. I was actually just asked to come and close this meeting. But so that's all what I've talked is not what I was asked. So let me close this, take this opportunity to close this meeting. Thank you very much for listening.